Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled A Community Health Assessment How-To, and it was presented by Robert Martiniano and Lottie Jameson on July 30th, 2014. But before we get started, I would like to take a few moments to introduce you to today's speakers. Robert Martiniano is a Senior Program Manager at the Center for Health Workforce Studies, which he joined in 2001. Mr. Martiniano has an extensive background in health workforce research and program management, including 11 years at the New York State Department of Health. Mr. Martiniano has worked with a number of organizations in developing community health assessments, including the Adirondack Rural Health Network and the Community Healthcare Association of New York State. Mr. Martiniano is also an adjunct professor at the Sage College's School of Management, teaching courses in Introduction to Health Systems, Strategic Planning, and Comparative Health Systems. He is also the health chair of the local NAACP chapter, on the board of the Hudson-Mohawk HWTAC, and on the New York State Workforce Advisory Committee, chairing the subcommittee on data and evaluation. Lottie Jameson is the Director of Regional Planning and Development at the Adirondack Health Institute. Ms. Jameson has been working with nonprofit health-related organizations for over 20 years. Most recently, she accepted a new position with the Adirondack Health Institute, serving a 9-county region in upstate New York. Ms. Jameson had been the Executive Director of the Hudson-Mohawk HWTAC since 2006. Prior to that, she was part of a project evaluation team at the University of Albany's School of Public Health, working with hospitals across New York State to reduce medical errors. She was also the Assistant Director for 2-county alcohol and substance abuse prevention program for a number of years. Ms. Jameson has also served on numerous health-related committees across the state of New York. At this point in time, I'm going to go ahead and turn the event over to our presenters. After the presentation, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure they have an opportunity to be answered. Also, when the event ends, you will be directed to a short evaluation survey. So please, take a few moments to provide us with your feedback. Robert, you should be good to go.
Thank you, and good afternoon and good morning, depending on where you are in the world. So I want to start by giving a brief overview of what a community health assessment is and then go into kind of the nuts and bolts. And at that point, actually, Lottie's going to talk about the experience that she had and I had up in the Adirondacks as we actually did community health assessments for a 8- or 9-county region as well as the hospitals. So I don't want to belabor the point, but community health assessments are used to understand and prioritize need in an area and ultimately allocate resources to those needs. In this state and in most other states, it's a requirement of the local health departments or the health districts to do these on a regular basis. Additionally, now the federal government requires not-for-profit hospitals to do community health assessments to continue with their not-for-profit status. When I initially did this slide, I talked about, if you've seen one community health assessment, you've seen one. And the fact is they are all different depending on who the lead agency is, how the data is being collected, the stakeholders, and ultimately the money that's going to be thrown at the project. So, as you think about, one of the things I thought about as I was preparing this was, do we need to do a template? But there's no template because it really is going to depend on a lot of community factors. So what Lottie and I are going to do today is go through these steps as I've outlined here and talk about specific issues around these. And again, we're going to go more in depth as we talk about these issues. Okay. So let's start with defining an area for assessment. Traditionally, most areas are defined based on political boundaries, counties, cities, and towns, and even zip codes in some areas. But that may make sense for public health departments. It may not make sense for hospitals and community health centers and other community-based providers that may either be part of a political boundary or cut across multiple political boundaries. In those cases, you see less formally defined boundaries. New York City, where we do a lot of work in, they have historical neighborhoods, and a lot of the time these assessments are based on those historical neighborhoods. But it's not just New York City. There are many other communities that have more of these informal boundaries. Additionally, when you think about hospitals and community health centers, you're really thinking about service areas. So who do they provide to and how big or small it is? And as you think about a service area for either a hospital or community health center, remember it may not be the same for the different types of services. So let's say a transplant service might have a much broader service area than primary care or the ER. So again, there's a lot of fluctuation in how service areas are defined. And the last thing I want to say about service areas is that sometimes you're also thinking about a population within a service area. So am I talking about Medicaid eligible? Am I talking about the homeless? In a lot of areas in New York State, we talk about migrant workers. So there are a number of ways to talk about your service area or the area you're assessing. And again, it's going to be fluid depending on who's involved and how they're involved. So let's start with I know the first thing on the list was identifying and engaging stakeholders, and Lottie's going to go into that. So I'm actually going to skip that and go into data collection. So as I think about data, I want to think about a couple things, like what data is available and at what level of geography is available. Or, is it available just at the county level? Is it available at a sub-county level, maybe a township, maybe a zip code? Because that may define how you collect data and what data you actually collect. Data can be secondary data for the most part, data that's collected by a health department, collected by the either health department either being a state or a county, maybe collected by a hospital, maybe some statewide or national surveys that you can pick from. There's just a lot of different places you can get secondary data from. And as you think about the data, also think about primary data collection. So what data can't you find that you're going to need to do some primary data collection on? Is it about the health status of your population? Is it about providers? There are a number of different ways you can collect data. And, you know, a couple of things and I don't want to belabor data too much, but there are a couple of things you need to think about as you collect data. One is, again, and I've said it a little, how many years and at what level of geography? So I know in New York State, a lot of times they report data in 3-year increments. The good thing about that is you don't have to worry about the year-to-year fluctuation. So if they collect data on outbreaks. So if there's an outbreak which actually happened in the Adirondack, there was an outbreak at a fair in one of the counties, and listeria or one of those had a spike for 1 year, and then it's down the next year. So, you know, you've got to, by having the 3 years, you can kind of even out those fluctuations. The other thing I want to talk about that, using that example as that fair and that outbreak, was you also want your stakeholders to help you explain the data. So when I looked at the data, I'd forgotten all about this outbreak, and the county health director says, oh yeah, this was so-and-so. Another example of that I had was when we were looking at smoking in the various counties, and one county seemed to be higher than every other county. So as we're talking to the stakeholders, they said, oh yeah, we understand that. There's a prison up there. A lot of families follow their family member who goes into prison, so they're bringing their behaviors with them. Additionally, it's very close to a reservation, so they get cigarettes cheaper. So, you know, even though the data says something, we want to be able to use our stakeholders to explain the data even further. You know, the other thing I like to talk to people about is using the data is how do you combine data to tell the story? you may see certain data that you have available, and as you bring in other data, and I'll give some examples as we go forward with this, how does that supplement the story? Do I want to bring hypertension, diabetes, hospitalizations, incidence of diabetes together and start talking a story about cardiovascular disease? Do I want to bring in other things around motor vehicle accidents and to start telling the story about motor vehicle deaths? So as you think about your stories and you think about your data, try to figure out what story you want to tell and how you can add to the story based on additional data collection needs. So now I want to go into some of the specifics about the different data that you can look at. So the first one is population data or demographics data. And I've given a long list here of the different things that's actually available. And we'll talk on the next slide about where they're available from. But the question is, what does your population look like, and how does that population and how that population looks impacts on either health needs or access to health care? So things I like to look at, language spoken at home. If there's a large population that doesn't speak English at home or English is the second language, then you know you may have barriers or you may need to do other type of programs to ensure those people get access to care. In upstate New York and in many of the Rust Belt states, we have an older population. So that tells us something about what we need in terms of the programs. The variable I like, which is actually at the bottom, is single-parent households. And the work that I've done in the community, to me, it's a good indicator of poverty when you see a high percentage of female single-parent head of households. Again, so as you look at the data, what does it tell you, and how do you draw stuff from it so that you can build your assessment? Okay, so where do you get data from? So the easiest thing, and I say easiest because sometimes it is difficult to navigate the census website, but the census now has data that they collect every year that allows you to look at your community. It's in 1 year, 3 year, and 5 year increments. And I listed the charts, and the charts that you're probably more interested in are DP2, 3, 4, and 5, which actually show you information by your community for the different characteristics. And if you want, at the end, I can actually talk about some of the different characteristics that are involved. The more years of data you have, the more geographic levels are included. So for year 1, you've got only big populations. Year 2, you've got more populations, and year 3, and by the 5-year total, all geographic levels are included. So if you're talking about, we've got a small county in New York with 4,000 people, which is probably relative to everything else. I can't get data on that county in 1 and 3 year increments, so I can only look at it in 5 year increments. I looked at, when I was doing this, I actually looked, and for the 3 year increment, 40% of our only 40% of our counties reported or along those lines. So again, as you think about how you're collecting data and what you want to say, you need to, you need to think about, am I getting all the things I need, and what level of geography tells me that? And again, if you're going to use the community survey, think about the 5 year data. The good thing about the American Community Survey, while you can download data and kind of mess with the data at your computer, they also have standardized reports. Again, I've listed 4 of them, and then the 5th one is actually centennial data. So most of the data that you want, you can get off these reports, and you don't have to worry so much about what am I thinking about. So you can get race, ethnicity, you can get age groups, you can get gender, you can get housing stock, and education and poverty, and a number of other data elements that helps you describe your population. So I want to go from population to overall outcomes, and I kind of collapse them into mortality, hospitalizations, and emergency department visits. So mortality, who's dying from what? Is it, and as you think about this data and all the other data you may be thinking about, you're going to be comparing against something. You may be comparing against other areas in that region, the state, the nation, but you got to think about how that data relates to what else is going on, and is it better, is it worse, is it higher, is it lower? So for mortality, I like to look at overall mortality, then disease-specific mortality. Cancer, diabetes, heart disease, things like that, again, start telling you something about your population. Same with hospitalizations. Try to break them down as much as possible, again, and link them to other data. So if I'm going to talk about diabetes mortality, I may want to also look at diabetes hospitalization, short-term complications, long-term complications, hospitalizations with amputations. So all of a sudden now I can take my outcome data, my mortality data, my hospitalization data, and actually bring in my health status data, which I'll talk about in a little bit, and start talking about, again, telling the story about what's going on with diabetes in my country, in my state or my area. The other thing that's a really good indicator of access to care issues is avoidable hospitalizations. They're called either avoidable hospitalization, prevention quality indicators, or ambulatory care sensitive conditions. It all really talks about the same type of behavior. What hospitalizations occurred because there wasn't enough primary care in the area that you're assessing. The other thing I want to look at is emergency department visits. Is it high? Is it low? How does it compare? Are they avoidable? Because it can tell me about access to care. It may tell me about tourist issues in the community. If there's a jump in the summer, I may be saying to myself, well, there are a lot of lakes, there are a lot of campgrounds, all those things are leading to a jump in the summer. Or conversely, it could be in the winter where you've got skiing or other things. So you want to look at that. And, other things I look at are injuries, especially for the very young and the very old. What's going on with poisonings for young kids? What's going on for falls for young kids and older people? And how does that fit in? Okay. So next, again, and I know this is really a rough overview of what we're talking about, because there's we could probably spend 2 or 3 hours talking about specific data elements, and I think it would get kind of onerous on everybody. But so the next thing I want to talk about is maternal and child outcomes, and similarly, you're looking at what's going on in the population. When I think about birth outcomes and rates, I want to look at overall rates. I want to look at teen pregnancy rates and teen birth rates, because it tells you something about your population. In some ways, in these, we're starting to also talk about places where you may want to look at differences if the data is available by health status or insurance status. Am I seeing more or less with Medicare patients? Am I seeing differences and disparities by race, ethnicity, or other type of things? You want to kind of understand your data and what it's saying. Again, as I think about linking data, this is another good example where linking data makes sense. So as I think about prenatal care, in this state we actually we know the percentage of women who have early or late prenatal care. So we can link those to birth outcomes. What was the average birth weight of the baby? What was the gestation period of the baby? What was infant mortality? So you can start taking some of these other data things, other data indicators, and link them and start, again, telling that story. Other thing I like to look at is vaccination rates and childhood disease outbreaks. What's going on? Are vaccination rates going down? All of a sudden we're seeing increases in measles or pertussis or things like that. But again, this is a case where you really need your stakeholders to think about are there specific populations that may not agree with taking vaccinations? We know that in the North Country there are a lot of Amish communities, and that may impact on the data, and your stakeholders are going to be able to tell you that. So we've talked about kind of outcomes. So let's go to now behaviors and status. So as I think about behaviors, I kind of break it into a number of different areas. Let's first talk about at-risk behaviors. So I'm thinking about smoking, binge drinking, eating, and exercise. So what are we doing? Are we exercising enough? Are we eating our 5 or 6 fruits and vegetables a day, things like that? Behaviors can also be, when was the last time you went to a dentist? When was the last time you went to a doctor? Do you have a usual source of care? Because those things, again, start telling you about access issues. I'd also want to know about health insurance status. Do you have health insurance? Do you have public or private health insurance? If you're over 65, are you supplementing it with, if you've got Medicare, assuming you have Medicare, are you supplementing it with Medicaid if you're in those kind of situations? And the last thing I want to talk about in terms of health status is diagnosis. So we use, in this state, we use BRFIS, or the Behavioral Risk Factor Surveillance Survey, a lot, and by county we can look at a lot of things. So we know the percentage of people ever diagnosed with diabetes, the percentage of people ever diagnosed with asthma or ever diagnosed with hypertension. So if you think about those indicators and you think about our outcome indicators we've just talked about and population indicators, again, you can start telling the story. Now, I know in this state we have a difficult time going below the county using our BRFIS data. So this may be a case where local community health surveys are necessary, where you're asking a community, do they have these things? I know in the Adirondacks, I think 5 or 6 years ago now, they actually did a community health survey, and they actually asked very similar questions about health status, health behaviors, so that they could do it at a sub-county level, talk about health needs. Okay. So, you know, I've kind of touched on this a lot, the availability of health care. And so what am I looking at? First off, I'm looking at where are my providers and what are they doing, and their hours of operation. I also want to look at what services they provide. Is it all primary care, or there's some specialty care? If specialty care is not available in the area I'm looking at, do I want to ask providers what their referral pattern is? How are they sending data of people out to other referral sources? I also want to look at shortage areas, and I actually indicated how to find both a HPSA and a health professional shortage area and a medically underserved area or population using the federal data set. One of the things I talk about, and I'll talk a little about, is the availability of transportation. So as you think about healthcare providers, how are people getting to those providers? The other thing you don't want to forget is public health. In many places, public health is a safety net provider. So are they providing a broad breadth of services, or are they limited to just a few primary care services or some specialty services? So you really want to, again, to understand all of public health or all of healthcare services, you want to make sure you look at public health. Okay, so, but once I've thought about where people are, I also want to understand what are barriers to access to health. So I want to look at insurance status, and we've talked about that a little. Are they underinsured? Are they uninsured? Are they Medicaid? Again, we've talked about providers a little, lack of providers, hours of providers. And this is where I can take some demographic data where I looked at language spoken at home, and are there cultural differences between the populations and providers. And the last thing I want to look at is environmental, geographic barriers. In a lot of upstate, in rural areas, you'll find lakes and rivers and mountains, and it's hard to go between them or around them. So it adds to time to get care. Also, lack of public transportation. Where is it? How often is it? Those things are going to impact on healthcare and accessing healthcare. So I want to talk about educational and economic data a little. So I'll start with economic. So using Department of Labor data, you can look at employment sectors. Where are people working? Are they on farms? Are they in mines? Are they doing construction? Or is it a service economy? Because all that's going to impact on both their risk behavior, what are they at risk for, as well as do they have insurance. I want to look at unemployment rates. And again, you can get those from your state or your state, local, or your federal health department, labor departments. Education, I like looking at, in this state we actually have a school report card. So by school district, I can actually look at dropout rate, free and reduced lunch and graduation rates, and that can tell me something about the population. I like linking free and reduced lunch to poverty levels. Okay, finally, environmental data, and this is probably one where you really don't have any good data source, and that's where you may have to ask people, you may have to do some of your own data collection. But what else is going on? What's the age of the housing? Obviously, older house leads to potentially leads to lead poisoning and asthma. We've talked about public transportation. Crime tends to tell you what's going on in your community too. And again, I mentioned this, but you know, when I was looking at the Adirondacks, that car accidents and vehicle mortality, I looked at speeding tickets, I looked at pedestrian accidents, again, so I can get the whole story. Here's some useful data sets that are national. And again, as you think about this, some are national, some actually do as in the county rankings, actually gives you county information. But the area health resource file, it's information at a county level, does healthcare professionals, hospitals, healthcare facilities, does include some other population data, but it's all in one place, where a lot of times you're going multiple places. BRFIS, again, but that's only at the state level, and you're not going to get much other than that unless your state captures its own. County rankings has a lot of data, demographic data, uninsured, limitations to healthy foods, health status, screenings. This is one of the places which, if you don't have your own data collection in your state, actually may be a good place, because it does, it pulls it all in one place and it's easier to get to. And also the last one is the Center for Health Statistics. And again, that's generally at the state level. Sometimes it's at the Census Division level, which nationally I think there are 8 or 9. And I actually also included our state prevention agenda, so you can see some of the things we've done with the data. At this point, I'm going to hand it over to Lottie, and she's going to talk specifically about the Adirondack Rural Health Network case study.
Hi, good afternoon, or as Robert said, good morning, depending on where you're calling in from today. I want to give you a little bit of a background as far as how we actually have used this over a number of years here at our organization. For those of you who are not familiar with rural health networks, there's 34 in the state of New York. The Adirondack Rural Health Network has been a program of the Adirondack Health Institute for over 20 years. We operate with a governance committee of 18 different stakeholders from different sectors of the healthcare system. And I see one of the questions already is saying what groups are likely to complete surveys such as this. And I think what we have certainly found, we have out of that 18, we had 8 public health directors. So here in New York State, our public health directors, through the New York State Department of Health Commissioner, were charged to complete community health assessments. So we'll talk a little bit about how to engage stakeholders, and I have found one of the easiest ways to engage them is that somebody else is requiring them to complete one. In a rural setting such as this, people have found it advantageous. We have a limited amount of resources. Our service area in upstate New York, this Adirondack region, is a little bit north of Saratoga up to the Canadian border. So we're used to trying to do an awful lot with very little. So this is a group that traditionally will pool resources and work together. And because of the work that the Rural Health Network had done in other venues with other programs, as our county public health directors were coming together, they thought, well, geez, is this a good thing for the Rural Health Network to become involved with, and maybe they can help shepherd and spearhead this. So I wanted to give you a little bit of background. That's what this first slide is representing. We've been doing community health assessment here 3 rounds over 10 years. Each year it looks a little bit different. Each round looks a little different. I think what you've heard Robert just describe is an awful lot of data that's available. I think our last analysis was over 300 data elements. The group itself had certain elements that they were required to submit and report on, but then they wanted to look at other things. The practice, I think Robert said it well, when you've seen one, you've seen one. You know, getting to that place of what do you need, what are you looking for, we still, and I'll talk in a few minutes about some things that are still missing. I think what we certainly have found is you're trying to give a really great snapshot of your population's health, and that's in imperfect science. We're doing the best we can, and starting with some data is better than no data, and measuring that is really what our group has been trying to do. So we looked, round 1 for us was probably 8 or 9 years ago. We focused just on what our public health departments needed, 6 counties at that time. There was a committee structure. They agreed on data sets. Each one of these rounds, we've used a different contractor to help us with our data needs. There was a primary survey data collection done with area residents. And again, this was a telephone survey. We, as Robert mentioned, we have high levels of poverty. You're only going to reach certain types of people at home during certain times of the day or the week. So we knew that there was some issues with that data collection, but we certainly felt like some primary data collection was needed. And what came out of round 1 was that transportation. This is a highly rural area. Robert mentioned we have some geographic, we have 46 high peaks. We have a number of lakes and rivers, and people will drive in different directions than you typically would think just because of the geography here. EMS was also identified as a high need. And really what we did with that first round is we really informed a lot of stakeholders as to here's a snapshot of our community's health. Round 2, at that point, hospitals also became involved and engaged, wanted to be a part of that. That was probably 4 years ago. And we certainly have been trying to engage more of our community-based organizations. We think of some of our not-for-profits that are doing things around behavioral health, homelessness, our local YMCAs. We could get folks to attend kind of a kickoff meeting to see, like, okay, what's this all about? To get them engaged in a process that it can take up to, you know, a year of regular meeting, discussion, decision making. We've seen the group has really been focused on our hospitals and our public health departments to date. And we certainly in round 2, instead of doing primary survey data collection, we used focus groups with community-based members. So we did something specific for EMS. Again, we tried to really look at where are folks already gathering. If there was already a meeting happening, long-term care providers, EMS, behavioral health, we tried to facilitate a focus group in that area at that meeting, and that helped inform our community health assessment for that period of time. And most recently, we've just completed, in 2013, we completed round 3. Probably for almost 2 years now. Our Community Health Planning Committee has grown. We now serve 8 to 9 counties, depending on what day of the week. We're adding new people all the time, and we now have a subcommittee structure that includes public health, hospitals, community-based groups, and a data subcommittee. So right now there's a full steering committee and 4 subcommittees meeting. Next slide. Community engagement. I think what I've seen the number of years I've been working around this project, as I said, requirements. Is somebody requiring you to collect data? Is it advantageous, certainly as a region, to meet and talk about different stakeholders that should be involved? Things that now you're looking at maybe potentially foundations, grants, different funding sources. Here in New York State, we're in the midst of a Medicaid delivery system redesign program. So now the impetus of potential millions of dollars to the region has certainly brought a lot more people to the table in 2014, and a community health assessment will be completed yet again, looking at some different data sets before December of this year. I would say over the course, again, I hope you're getting the sense that this was a group that had been meeting together. You certainly are trying to look at where are things that people can reach consensus about. What's the bigger picture? You have to be able to build trust, and you have to kind of give up control. So we really convene, we facilitate. What we think the end outcome is not about us, it's really about what the group wants to achieve. You probably have worked, I talk about this in a lot of different ways. You know, collaboration, I think we all can talk about it, but I don't think you see that occurring as often as we would like. You know, I think people, oh, maybe we'll work on something together, we'll partner, but true collaboration is really giving up control, and you create something by working together. So giving up your power, giving up control, I think that's a key to the community engagement piece. We've also learned that we have to be open to new players coming at the table. We are very much working in a turbulent system of healthcare, and so we have different entities coming into our region. Recently, a lot of our public health departments had their own home care projects and programs, and they have recently been bought out by a private company. So now we have, you know, new players in our community around a really important sector like home care. You're also really looking to make sure that you have active participation by everyone sitting at the table, that to really achieve the goals of the group, you want to hear everything, including some of the naysayers, because you want to address those issues as soon as you can. People have to be willing to share information, share resources, and to be open with their comments. I think otherwise we've probably all been involved with groups that don't do that, and you find a real stagnant, you know, lack of energy, and then we start wondering, why are we even attending this meeting to begin with? One of the things we've definitely tried to balance is the structure. So we really look at things like timelines, deadlines, when do things need to be done. You want to create some structure, but knowing that we also have to be flexible. A lot of times our timelines are 12 to 16 months, knowing that we need some flexibility in the midst of that. And certainly making sure that everyone's validated and respected, and that can be one of the biggest challenges for the convener. This goes to that skill, you know, making sure that you can cut back on some ancillary discussions, or I'm sure we've all had folks that want to take the stage over, so knowing how to skillfully manage that and move on to the next topic has been something that we've learned to do as well. If issues arise, I think one of the biggest things as the convener and the facilitator that we've had to do is we go out, we find that information, we may need to bring in an expert, but we share that amongst the whole group. I think that's one of the things that has really helped us in our success here, and again, we're really trying to reach consensus at the end of the day with all of this. So, next slide. Again, we've looked at things. I think if you're looking at doing a community health assessment here in New York State, we do have some, you know, resources recently built for a data warehouse. But you have to look at both a qualitative and a quantitative. These were some of the things we looked at. I think Robert mentioned a couple of case examples of where, you know, sometimes when you actually look at your data, your understanding is, well, there is a reason why this is different or outside of the norm. So you want to address those things in a qualitative manner as well. Other stakeholder input for us under the data collection, it's been interesting to work with some other groups and realizing, in this day and age, the last few years of EMRs, EHRs, we kind of just assume that lots of groups have data. Our behavioral health group here in the Adirondacks has no electronic reporting system, so for them to share information with us is not the easiest thing, and right now they're really advocating to find some funding for that to happen. So I think anytime you're looking, you want to make sure you have all sectors of your healthcare system represented if possible, and where those gaps are, it's important to bring them along in the future. Next slide. Under methodology, I think what the fortunate thing was we have a prevention agenda here in New York State. 6 years ago it had 10 agenda items. It now has 5. Each of those prevention agenda items have data sets attached to them, and they also now have evidence-based best practices for strategies to move forward. So I think our analysis here, we looked at things, county level, we looked at the region, we then would compare them to rates for upstate New York and or New York State benchmarks. I think what's interesting in New York State is always upstate is considered anything outside of New York City. So for us, we have one county that's a frontier county with less than 5,000 people in its population, and yet that could be compared against a Syracuse, Rochester, or Buffalo. So I think, this is where each of our counties and those hospitals or public health directors really had to look at their data and say, am I worse than the benchmark? Is that anticipated? Was that unexpected? And how much worse were we? So that speaks to this, being put into a quartile and being able to really look at things compared to your adjacent counties. And what we were able to do then is, look at things based on focus areas like chronic disease, some of those other indicators that Robert mentioned, and certainly individual data elements. I think where we're at right now is we're looking at things like how much the social determinants of health really impact some of these things. Primary care access, where's the workforce, where are they located? So, next slide. This is an example of, some of the methodology. It gives you some, a snapshot of some of the reports that would have been presented to our work group. So I think in the interest of time, I'll probably move through these relatively quickly. It looks like you will have access to these slides tomorrow by the looks of it. So let's, Robert, you want to just move through those, or I'm not sure if you wanted to add anything with that?
No, I think that's fine right now.
Okay. And so the regional and emerging trends slide, there was, as I mentioned, each round of our community health assessment, the group would determine, well, I think we really need to look at some other things, or we want to do some, again, the telephone survey was one example, the focus groups. This last round, we looked at, we worked with the University of Albany School of Social Welfare. They looked at some, we did what we call a community provider survey, and that survey went out to a few hundred of our community contacts, and we asked them a set of questions as far as, what's your, most pressing, health-related issue. So that's kind of to the left. Your emerging theme is what we saw there. The population group needing the most service, or need in targeting service. So you'll see things like our migrant workers, farmers. We still have quite a few farms in our communities as well. I think anytime we're looking at data like this, we're looking at things like, oh, could someone help us prioritize where we should be focusing our efforts? And as you can see under emerging themes, we've got a category called other that 35% selected as, oh, that's something else that's not here in this list. So certainly obesity, chronic disease, substance abuse, mental health are always, have been some of our biggest concerns for the region. And then under the target, we have a large, section of our population that is poverty. Should we be focusing on the elderly? We also have one of the oldest populations outside of Florida. when you look across the country, this part of upstate New York, we have a large elderly population. So this was just trying to really take the data and the numbers and tell that story and really start to look at what do other groups need or think we should be focusing on with our community health assessment. Next slide. So our health trends, what was top emerging for the group to really consider is growth in the obesity rates, chronic disease, no real surprises here. In a more urban setting, you might see HIV. That was the least importance for us. Certainly trying to use technology has become an interest because it could help us with access to specialists that we don't have in the region. And certainly folks are worrying about future funding and where they're going to be going with reimbursement for their services. Next slide. One of the things that the committee that started in the data subcommittee and went up to the full committee to discuss is how do we do a better job of prioritization. In the second round, we actually used an option finder, electronic method of selecting priorities. People had to sit through 280 different data elements and try to prioritize them. So people felt that was painful and did not want to repeat that process. So we were looking at different ways. There's a number of different ways out there. We actually got it down to two. We looked at a dot method and a weighted method, and we had to look at some of the key things that we were going to use for prioritization, and we'll give you an example here on the next slide. So what the group determined they wanted to do, this is kind of just the overview, is that, the stakeholder survey would be given a certain weight, there would be a need, and I think this slide actually scrolls down a little bit, but we would weight certain elements, and then we would also try to give it a severity score. We would score it a high, medium, or low, and so those things taken together help prioritize the different data elements that were being looked at. Next slide. So this just gives you an overview on the left-hand side. These would be the data elements, the group, the committee. Over 30 representatives from different sectors would say, how severe is this problem? Is there anyone else? Is there a need for this? I think one of the things this process in 3 rounds has taught us is sometimes there's another organization that's addressing it, and so this group is really trying as a region to determine where the gaps are, and those tend to be the things that we focus on moving forward. Next slide. So the takeaway from all of that, so we spend, probably a year in and out of meetings, we're looking at data, we're doing prioritization, then what? Somebody that I've worked with says, okay, so you got all this data, so what? Oh, the so what for us, priorities were identified to be chronic disease and obesity. A new committee was formed. PANTF stands for Physical Activity and Nutrition Task Force. They worked with our Community Health Assessment Committee and subcommittees. And here's some of the things that the group determined they would do as a region. So again, identifying a need, where's there a gap, what are we going to do collectively? And this is just a listing of all the things that were done between trainings, mini grants, resource directories, and then also training our work group on how do you actually evaluate some of the strategies and the work that was being done. Next slide. So what worked? I think anytime that you can bring a group of people together willing to share information, resources, I think what we saw was we have one county that's relatively affluent compared and has a large population compared to the others. So they certainly were able to share some of what worked for them. I think people, were again trying to really determine how do we best collectively do this, because we're also strapped with resources, time, funding. So the whole sharing in and of itself is really, I think, the biggest piece that works, and the learning that happens in that process. And I think you also found that the region as a whole, and certainly working with us at the Rural Health Network, you know, we could really highlight and, you know, bring one particular issue to the forefront. So we focused on, you know, the impact of physical activity and nutrition, and if you didn't have that, what did that lead to? Obesity, chronic disease increase. So that was really probably the pieces for us that we would say have worked the best. Next slide, we talk a little bit about what could be improved upon. I think, you know, and what I highlighted there is what we achieved in 2009. You say, geez, 2009, that was a long time ago. Well, we spent, 2009, we finished that assessment. We spent a couple of years doing the mini grants, holding the conferences. We just finished our last round of assessment in 2013. Right now, we're doing our executive summary to disseminate out to stakeholders. And I think what we've certainly found is that there was a lot of variation. There's many impactors to particular issues and health concerns that vary. And so for us to say, oh, we've made a difference in this X, Y, or Z has been difficult to do that. So again, these are people just coming together saying, let's do what we can, rolling up their sleeves. It's not as if we've received funding to do a research project around these types of things. So I think we also have found most of our community health assessment has been focused on hospitals and public health. I think that'll change here later in 2014. Again, because of the requirement with the Medicaid delivery system redesign. But we really need to broaden that snapshot of a population's health. And we haven't really done, you know, the year by year or a couple of years, some trend analysis. We've really looked at data in those kind of components of, are you above or below your region? Are you above or below upstate New York? Are you above or below New York State? So really trying to use some trend analysis to see what's working is probably something we're going to look at moving forward on. And again, now our prevention agenda has a big piece with the social determinants of health. So that's really something that's been outside of, you know, where are we with our education level? Where are we with our employment level? Where are we with housing? And there's a lot of other impactors in there that are going to impact health. And I think we've also gotten to that place of we now have done 3 rounds of data collection and dissemination, but we have to do a better job about an analysis and a presentation so that even my grandmother would say, oh, now I see why this matters. You know, the so what is, oh, this is why this is important. So these are the things that we're going to be moving forward on 2015-16. Next slide. So, why do all of this? You know, we're really looking at that structure of a systematic, data-driven approach to look at health status, behaviors, and the needs of your population. With that, we can start then formulating strategies with the goal to improve our community's health and wellness. Here in New York State, we have a mandate for every 4 years. Unfortunately, with our Department of Health, it does not align nicely with what our hospitals need to do, but we're working with that as well. We also have a template. We have a structure with the prevention agenda. So that kind of defines or starts us out with where we need to look, what we need to look for. And we certainly are looking at how do we collaborate to define those priorities and then move forward. And I think that's it for me.
Thank you, Lottie, and thank you, Robert. That was very informative. At this point in time, we're going to go ahead and begin the Q&A session. For any of you who have questions, use the chat panel on the right of your screen to send them in to us, and make sure you address it to all panelists. With that said, I have one right here for you already. What other organizations in the future will be encouraged to participate in community health assessments?
The ones, you know, I can speak to, I know what we've identified here, a lot of our emergency medical services are volunteers, so we've had a difficult time getting them at the table, yet there are pre-hospital, you know, transport mechanism, they're a key piece. I think we're trying to re-engage some behavioral health, mental, emotional behavioral health providers as well, and using a group. They were already meeting as a group. How do we weave them in? Making sure that long-term care and home care are also engaged. Those would be the key ones that we would be looking forward to adding in 2015.
Okay, next question. Have you been able to engage primary care providers in participating in a community health assessment?
We have, we're actually co-located with one, yeah. So I think, and again, they have 15 different locations. They have, out of our population, they serve about 70,000 patients. And when I say hospitals, a lot of our hospitals also have primary care practices attached with them. So we do have primary care involvement in kind of inherently with that group as well.
Okay, and is there a report of findings from this community health assessment?
There is. It is published. Our most recent one from 2009 sits on our website, www.arhn.org. And the newest summary will be done in the next month or so, and that update for 2013 will be posted there as well.
Okay, one more question. Robert, how would you assess the impact of multiple births on birth outcomes?
I would actually, because when you think about low birth weight, you think about gestation period, multiple births can negatively impact them both. I would actually, if possible, take those out and look at again, the low birth weight and the gestation period separately outside of multiple births, and then see how multiple births impacts on them. Just again, because it does skew the data a little.
Final question. An early slide talked about available resources needed to conduct a community health assessment. How did the Adirondack Regional Health Network support this effort?
Support, yeah, I mean, I think that's a big piece. It's a big undertaking. It's a big investment. We are funded, the Rural Health Network itself is funded through the Office of Rural Health here in New York State. It's one of the departments in the Department of Health. So a substantial part of that funding is earmarked to do this. But we've also looked at other sources of funding, other sources of support. In kind, certainly a lot of our committee members also roll up their sleeves and join in that, and we have some experts in some of the different data collection methods, and so in kind is a piece. I would say that we've also probably been it started in round 2. There were some ancillary services that 6 to 8 public health departments, 8 hospitals determined they needed, and so with that we've actually done separate subcontracts. Again, it's a generic contract for 16 entities, and it's specific to community health assessment and what they would like to see done, and that's an annual contract, so that brings in some additional fee-for-service revenue to get the work done.
Thank you, Robert, and thank you, Lottie. That was very informative. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.